Good afternoon. This is Valerie Cape at CMQCC. Welcome to our webinar this afternoon. We will wait a minute or so to let people get online, and we will start shortly. Thank you. Courtney, it looks like a fair amount of folks have joined the call. If you'd like to go ahead and start, I'll turn the time over to you.
Great, thank you, Valerie. Hi, everybody. We're so glad you're with us for our 6th webinar and our COVID webinar series. Today, we will be discussing breastfeeding guidance, and this webinar is co-hosted by CMQCC and CPQCC. I am Courtney Nisbet, Associate Director of Quality at CPQCC. It has been just a few weeks since we've last connected via our webinar series, and we are really thrilled to gather with you again today virtually. Today, we will be drilling down deeper on a very important topic of breastfeeding. We will be discussing the AAP's and CDC's evolving recommendations on how to support our patients and families around breastfeeding and COVID-19. We thank you for your continued efforts to support the mothers and babies throughout the state of California and beyond, and we're so glad that you're here with us today. Next slide, please. Just wanted to go over a few webinar logistics. All attendees are automatically muted upon entry, and the chat function has been disabled. We ask that you please utilize the Q&A box if you are having technical difficulties or to submit any questions you have for the presenters. We will be selecting a select number of questions relevant to the topics presented today during the Q&A portion of the webinar. And of note, the presenters have requested that participants add to the Q&A box what alternative breastfeeding support you're offering at your facilities. The remainder of the questions may be used to inform topics for a future webinar planning. And the slides and webinar recording will be made available on our COVID resource website. And due to the rapidly changing guidelines around COVID-19, the slides and recordings may be taken down after a few weeks. Next slide, please. Just want to go over a disclaimer in that the information shared in this webinar series and on our resource site serve as examples of how hospitals, healthcare workers, and families in California are responding to COVID-19. We understand that each hospital is unique and that they have a different set of resources and constraints, and some of the recommendations presented may not be applicable to your hospital setting. Guidelines and recommendations should be adapted to fit your local needs. And as this is a rapidly evolving public health situation, we encourage you to consider the most recently available local health department and national guidance when developing your internal protocols. Next slide, please. And now I'd like to introduce today's presenters. We have this excellent team from throughout the state of California, and these include perinatal clinicians from Stanford and the California Breastfeeding Coalition. We will close out the webinar as mentioned as time allows with a Q&A session. And I'd like to recognize our physician leaders at our California Quality Collaborative. They include Dr. Elliot Main, Medical Director of CMQCC, and Dr. Henry Lee, Chief Medical Officer of CPQCC. And now I'd like to turn it over to Dr. Elliot Main, who will start with a California COVID-19 update. Elliot.
Thank you, Courtney, and welcome everyone. We like to start these webinars with just a few slides about the epidemiology of COVID in California and around the states. Next slide. What you see here is the evolution just in the last month and a half As you know, we had a big peak of a secondary peak in COVID in July that hit our Central Valley in California. You could see the red dots inland in California, but particularly tough on Texas, Louisiana, and the Deep South. Fast forward to the data that we have as of yesterday. You can see it's considerably better in California and in the West than it had been. And then now there's pockets, particularly in the Midwest, in some residual places in the Deep South. Next slide. When you look at another parameter of assessing incidence of disease, that's what proportion of your tests are positive. There are still some outlier states, particularly South Dakota and still in the Deep South, but you can see here Iowa, Nebraska, Wisconsin are surprisingly high, 15, 18, 17%. California is down at 5%. This is the average over the last 2 weeks. The governor announced this morning, actually, that we were at 3.5% for the last 7 days, though there's a caveat there that there were a lot of tests not reported because of the fires and emergencies that we have in our states. So we're lower. We may not be as low as 3.5, but we're certainly in the right direction. Next slide. This again gives us a sense of new reported cases. On the left slide is where we were by June 2nd. That is then put into the red box on the right-hand panel, showing you that that was actually a pretty slow rise, and our big rise in July and August. And September looks like we are starting to see a real downturn, both in the red graph on the top in new cases by day, and then the gray plot on the bottom, which is new deaths by day. Deaths, of course, lag behind new cases by about 2 weeks. But you know, there's cautious optimism here about the level of disease. Next slide. Just, you know, California is such a state that we have very different regions in terms of frequency. I put 4 regions on 4 counties to represent those regions. Los Angeles County has a double peak, and it is the most cases by far, of course, being the most populous state in the most populous county in the entire country. But it is now clearly on the decline over the last 2 weeks. Santa Clara County was the first big bump in the United States, actually, in March, and it went way low, now went up again in the summer surge, and now is quite a bit lower than what it was in March, both in terms of positive patients on the top panels here, and then the ICU cases in the middle. Sacramento had very low, representing the Central Valley, and then had a big spike in July, and that's also the case for Fresno County, which had almost no cases. And it should be noted that the Fresno and Sacramento in this are dominated by Latina cases. Next slide. And this is represented here by the effects on different populations by race for both deaths and positive cases. The proportion of California population is shown on the right. 39% of all adults in California are Latino, representing 61% of the cases and 48% of the deaths. Black populations have also been disproportionately hit in California, representing 6% of the population, 8% of the deaths. So between Black and Latinx population, there's 56% of the deaths in that population alone, and that is what we're seeing when we go around the state. Next slide. When we initially started our surveillance with obstetric leaders, it was a very low rate of asymptomatic positives, generally about 1% or less, depending on the hospital, and a relatively low number of ICU cases. Next slide shows you what happened in the summer, mid-June to July, with a rise in Latinx patients, particularly in the Bay Area. In Southern California, saw big distinctions between hospitals that served high-income patients that had very few COVID positives and much higher rates in hospitals that served lower resource or minority populations. Again, a relatively small number of ICU admissions. Overall, we've had 3 maternal deaths that the state is aware of from COVID-19. Next slide shows you a big change in the last, through the end of August, now with a lot of concentration in the Bay Area, in Southern California, and Central Valley, and Latinx populations, with higher rates of positive, asymptomatic positives, particularly in the Central Valley. Southern California now has fallen back down to under about 1% or less in hospitals serving high-income populations, but a surge in Southern California in low-income populations. There's been several patients on ECMO, but they have gotten off ECMO, which is a huge relief. And a lot of the antepartum patients that were very sick have gone well. We've had almost no cases of infants reported in the state. And that really opens up today's discussion about breastfeeding and new and better approaches to supporting mothers with babies. So I'd like to turn it back over to Dr. Susan Crowe, who's a statewide leader in breastfeeding on the maternity side. Thank you.
All right, good afternoon, everyone. Thank you for this opportunity. Next slide. I'd like to start with giving some background about breastfeeding. That we had a recent report card released regarding 2017 data. And you can see here in California that we are doing better than the nation. However, there are many opportunities exist to improve our breastfeeding outcomes, especially when it comes to exclusive breastfeeding and the potential rising use of formula in the first 2 days of life. There are disparities that also exist in breastfeeding outcomes with regards to low-income families, and to be cognizant of that as we go through this talk today. Next slide. We know that what we do during the birth hospitalization has an impact on breastfeeding outcomes. We know that hospital policies, that the 10 steps have been shown to improve breastfeeding outcomes. And I'm going to talk a little bit more today about what we do in the care right after birth and the support mothers receive via rooming in, the care with skin to skin, responsive feeding, and practices in the hospital that are known to improve breastfeeding outcomes, and how our recommendations have evolved with regards to COVID-19, and what we can do in our hospitals now with updated recommendations. Next slide. And so this shows here a brief timeline of what I'll be going through. And I want to emphasize that in February of 2020, the CDC did come out with some initial guidance, but very little was known. In the month of April, many of us were establishing algorithms in our hospitals with what to do regarding our birth practices. And so since that time, that has transpired, we've had new recommendations in end of July and beginning of August from the AAP and CDC. So I'll be talking about how it may be time to revisit, and we have a few more answers to questions that we didn't know about initially. Next slide. So back in February, the initial guidance was to strongly consider separation from the CDC when moms were confirmed positive with COVID or PUIs. And the reason for that was that there was a lot of fear, a lot of unknown. We had some data out of China. That data was based on their routine separation for 14 days when a baby was born to a mom who had COVID-19. So we didn't have data about what would happen if they stayed together, and out of an abundance of caution, this initial statement was put out by CDC. Next slide. The World Health Organization, I don't know exactly when they came out with their recommendations, but by March of 2020, they had given some different guidance saying that even if a mother has COVID-19, she would be encouraged to touch and hold her baby and breastfeed. However, it was known even from the beginning that good respiratory hygiene would be needed, and we would want to prevent exposure to respiratory droplets. The moms were encouraged to hold the baby skin to skin and share a room with the child based on the knowledge that the absence of these things would interfere with the establishment of breastfeeding. Next slide. Excuse me. So the AAP initially came out with guidance on April 2nd. And this guidance was strongly recommending that the separation, temporary separation of the mother and newborn would minimize the risk of infection to the baby. The mother would have, and it's been a theme throughout, that the mother could refuse or decline and act in spite of recommendations, but that it would be on the mother to decline this separation. And then if she declined that, then to keep 6 feet apart as much as possible. And then of course to use respiratory hygiene. There was no recommendation at any point from the CDC or the AAP to withhold breast milk from the baby. It was a matter of this issue of separation. Excuse me, next slide. And so a couple days later, you'll notice these dates are 2 days apart. So likely these were being developed at the same time. The CDC came out with a change from their initial recommendation to separate to instead use shared decision-making and to consider things on a case-by-case basis. Next slide. And so recognizing the benefits of mother and infant skin-to-skin contact, and recognizing that it's not clear what the risk of transmission is or if infants would become severely ill. So that information wasn't clear at that point, and they point that out in their recommendation. Next slide. So the question then is to separate or not, and what do we consider? But in brief, if a mother was not going to be able to maintain separation after discharge from the hospital, then it would be considered better for her to stay with her baby in the hospital and establish breastfeeding, and then be able to teach her respiratory hygiene, hand hygiene, and to facilitate that teaching while she's in the hospital, that she could continue that care post hospital discharge. We also wanted people, the CDC wanted people to consider the desire to feed directly at the breast and the testing results of the mother and infant. If the infant was tested positive, then there would be no longer a reason to keep them separated with precautions. Next slide. And so they did say in the situation of co-isolation to keep the newborn 6 feet away from the mother. And so keeping in mind that this 6 feet of separation is recommended for for moms who are, and at the time it recommended as well for moms who are positive for COVID, and to consider physical barriers. So the important part about this to keep in mind is that it naturally may make it more challenging for a mom, and she may need additional support to establish breastfeeding. Next slide. ACOG came out with a similar statement. So far, the virus at that point had not been found to be in breast milk, but there was not enough information about whether or not women who are sick can pass the virus through breast milk, but also acknowledging that breast milk gives protection to babies against many illnesses, and that there would certainly be consideration of that, and to make this decision in joint effort with the family and the healthcare team together. Next slide. And so in terms of, there were some additional instructions that came out for the breastfeeding mother. In clarification in May, she should wash her hands, and if not, she should use hand sanitizer, and she should wear a face covering while feeding at the breast. Next slide. I'm going to skip through a couple. Well, I'll mention that express milk, though, it was not ever recommended that be withheld from the infant. And here it says that express milk should be fed to the infant. and in this situation by a healthy caregiver who is not at risk for severe illness. Next slide. There was also CDC recommendations that came out for advice for breastfeeding employees. I'm going to skip through these next two slides in the interest of time, but I'll leave them here for your reference. So next slide and next slide. Okay, so during this time, April 2nd to May 20th, there was information that was difficult for people to interpret in terms of absolute guidance. So the CDC was primarily recommending shared decision-making based on the factors mentioned. And then the AAP was primarily recommending separation of dyads. During that time of ambiguity, that's when we were mostly establishing and developing our algorithms. Next slide. So patient counseling at that time was considering both sides. So what was not known, and this was an example of information we shared with our patients, we didn't know if infant separation would decrease transmission or to what extent. We didn't know how long someone remained contagious at that point. And we didn't know if babies who have required hospitalization for COVID, we didn't know whether or not they were breastfed or not. So it was difficult to draw any conclusions at that point. Next slide. What was known was that there hadn't been at that point any neonates less than 28 days old who had died from COVID anywhere in the world. And the 2 infants that had died of COVID-19 were under some investigation, but it wasn't clear that COVID infection contributed to their deaths. And the number of infants, it was evolving further that we knew the number of infants who got sick with COVID-19 was small in comparison to adults. Next slide. We also know the benefits of co-location. So when we are thinking about implementing practices that may make it more challenging for babies to establish breastfeeding, it's also important that patients, we knew at that time, to be informed that there also are risks to these separation and that infants can benefit from co-location with the benefit of establishing breastfeeding more easily. Infants who are not breastfed have 3.5 times the risk of being hospitalized for pneumonia compared with infants who are breastfed exclusively for greater than 4 months. So, and there's a lot of data to support the clear evidence that breastfeeding is protective to babies. And so when we implement separation or even co-location where infants and mothers are not able to easily establish breastfeeding, those things need to be taken into consideration. Next slide. And then the benefits of mother-infant separation would be for people who are able to continue separation after discharge, there would be consistent practices across the hospital and the home environment. And it may be also temporarily easier for mothers or staff if the mother is very sick. And certainly in the ICU, there would have been and there would be reasons for that separation. Next slide. So initially, as you recall, the CDC had recommended a shared decision-making as the primary mode of making this decision. And the AAP was recommending strongly separation. May 20th, the CDC came out with recommendations to strongly consider separation, although recognizing that that may not be feasible. And we know that many hospitals who were hit the hardest with surges physically didn't have the space for separation. And that the risks and benefits of separation should be discussed with the family, but still relying on actions in accordance with the mother's wishes. Next slide. They slightly, they also slipped in though that separation could now be defined as in the clinical setting of either being in a separate room or maintaining a physical distance of 6 feet in the same room. Next slide. And then of course to consider the clinical condition. Next slide. So it still reinforces that breast milk is the best source of nutrition. And again, at no point, and it was considered that there was limited data available now though to suggest this is not likely to be a source of transmission, that breast milk was not likely to be a source of transmission. Next slide. So over the summer, as things evolved and more data was accumulated, we were able to give a little bit more information to our perinatal units about COVID transmission to neonates and the risk to the newborn. So about 2 to 5% of infants born to people with COVID-19 will test positive for COVID-19 in the days after birth. There at that point had been now are published reports of infants who did require hospitalization before 1 month of age due to severe COVID-19. We know that these cases are rare, but they do exist, and that families can now be informed that this risk of acquiring infection during the birth hospitalization is very low if we put in place respiratory precautions. Next slide. Rooming in there was now accumulating evidence, and in particular in the National Perinatal COVID-19 Registry, that an infant's likelihood of testing positive for COVID-19 was going to be similar whether they roomed in or whether they were separated in different rooms. So we no longer at that point are recommending, did I lose my connection? Oh, you can hear me. Okay, sorry about that. That we're no longer recommending separation as a mode to decrease transmission to newborns. Next slide. And so they recommend rooming in and usual practices with the consideration of wearing a face mask and performing hand hygiene prior. Next slide. They do recommend that routine delayed cord clamping can be performed, and that mothers, they do recommend bathing the infant. They don't recommend a specific timing, and I'll talk about that a little bit at the end regarding the timing of the infant bath. There's no further mention of breast hygiene, which had been mentioned initially and led to some confusion about breast hygiene practices. Next slide. So the AAP comes out as strongly again in support, though, that breastfeeding is not contraindicated at this time, and that the virus has been detected, viral particles have been detected in breast milk, but it's not known or thought that these virus particles are infectious. And although it's not yet established that there are protective antibodies in breast milk, what we know about breast milk is that this is certainly possible. Next slide. So breastfeeding mothers are asked to perform this hand hygiene, wear a mask, and if she chooses, she can express breast milk, and this can be fed to the infant. Mothers of NICU babies in particular are suffering from the need for separation due to safety and infection prevention concerns, but that their babies can receive their expressed breast milk. Next slide. So I'm pointing out the discontinuation here of protocol to prevent infection. Because although we are now recommending rooming in, the AAP is now supportive of rooming in and of practices to support breastfeeding, there's still a significant burden that is placed in terms of keeping 6 feet apart and not having as much contact unless it's necessary with the baby. So after a mom has been afebrile for 24 hours, and at least 10 days have passed since her symptoms appeared, and her symptoms have improved, she no longer needs to maintain that distance. Symptoms improved does not mean they have completely resolved. We know that there are lingering symptoms, as with many respiratory illnesses. Cough can persist for 4 to 6 weeks or even longer, that fatigue has been noted, but that the symptoms need to be improved but not necessarily resolved in order for her to discontinue these precautions. Next slide. For NICU visitation, these precautions also may be extended for severely immunocompromised individuals or for people who were severely or critically ill with COVID-19 for up to 20 days, and that may be necessary. And not to use PCR-based criteria, as that may unnecessarily impose restrictions on visitation. Next slide. So then the CDC, a few weeks later, came out with very similar recommendations. Some of the differences is that they include that there's insufficient data to make recommendations about delayed cord clamping and immediate skin-to-skin for the purposes of preventing COVID-19 transmission, meaning that disallowing skin-to-skin, preventing skin-to-skin has not been shown to decrease the transmission of COVID-19. There just isn't data to support preventing that practice. Next slide. And current evidence shows, again, that these babies are, the majority have very mild symptoms. And more precautions may need to be taken in the case of otherwise ill babies or preterm babies, and they may be at higher risk for severe illness. Next slide. The CDC again reinforces that rooming in is the ideal setting. And so this is in stark contrast, I'll remind you, to when these initial protocols algorithms that we've developed for our hospitals were taking place, there was not a recommendation for rooming in. And that, again, though, maternal autonomy should be respected. Next slide. And we know that, and the CDC calls out that these rooming in is going to help with the establishment of breastfeeding. People can respond to feeding cues, and that mother-infant bonding is facilitated, and that this is something that has many benefits. Next slide. They do have the same precautions. They further define, the CDC further calls out that the severely immunocompromised would be someone on chemotherapy, someone within 1 year of an organ transplant, someone who has been on prednisone for 20 milligrams a day or more for greater than 14 days. And they call out some of those things. And then they specifically also call out that end-stage renal disease and diabetes and other factors are not to be considered severely immunocompromised. There's a lack of specifying related to pregnancy, but in terms of their recommendations, they call out more specifically who would require that 20 days in duration beyond to protect from infection. Next slide. They do call out also separation may be necessary in higher risk infants. Next slide. And so, again, this is reinforcing the mask and hand hygiene. Next slide. So we know that that these practices can interfere with the establishment of breastfeeding, and we know that exclusive breastfeeding matters for both short and long-term health outcomes. So we want to consider that when we are making recommendations, and so especially when it comes to the risk and benefits of discontinuation of policies that may restrict skin-to-skin and the ability to room in to detect feeding cues and to learn to establish breastfeeding. Next slide. Here we see the synergy of the 10 steps when we allow rooming in, as well as skin-to-skin and other birth practices, that we see that there's an increased likelihood of breastfeeding improved breastfeeding outcomes. Next slide. And this specifically looks at skin-to-skin care, and there's been a lot of discussion, and I'll address some of that at the end in a question and answer session regarding skin-to-skin. We see profound impacts on the ability to provide skin-to-skin with increasing breastfeeding outcomes and decreasing disparities that we know exist. Next slide. So as we look at the populations that have been hit the hardest when it comes to COVID-19, we also see a population who may be less likely to object to any of our recommendations. And we want to be careful that our algorithms are updated and that we are not inadvertently disproportionately having a negative impact on populations at risk. Next slide. We know that skin to skin for the mother has benefits in terms of her stress and her benefits, and it enhances the opportunity for the early first breastfeed. It's well known as the golden hour, that time where babies are most able to intuitively learn to suckle and breastfeed directly at the breast. Next slide. We also know for the baby that there's great benefits in terms of stability, blood glucose levels, and multiple other factors. So when we do find it necessary to separate moms and babies, we want to consider the risk and benefits of those practices. Next slide. The newborn bath is one last thing I am going to bring up. As I said, the AAP is recommending that babies be bathed. They don't specify when. We know that there are benefits of the vernix that babies are often covered with or have at birth. We know that delayed bathing is associated with increased exclusive breastfeeding if delayed for greater than 12 hours. So we want to consider, with the knowledge that respiratory droplets can infect babies. And so we want to balance that and to protect babies as best we can while protecting their breastfeeding relationship. Next slide. I'm going to turn this over to Robbie Gonzalez-Dow, our Executive Director of the California Breastfeeding Coalition, to address these next slides.
Thank you, Susan. So just we've seen many changes in the recommendations. The State Department of Public Health has also updated their visitor guidance in early August. And so now they do recommend that doulas may be permitted into the facilities. So what needs to happen is just prior arrangements need to happen, and with the hospital and the doula to ensure that they comply with hospital PPE and infection control measures. And the research shows that there are very positive outcomes for including doulas as part of the care because they provide continuous care during labor, and so they show a decrease in cesarean section, and they also increase the likelihood of a spontaneous vaginal birth, and they also improve the satisfaction of the birth experience. So it's all very positive. One other thing that I want to mention about the visitor guidance that's related to the NICU and PICU patients is now CDPH recommends that 2 designated support persons be allowed to visit at the same time. So that's another important change. Next slide, please. From, let's see, late March through the month of June, we conducted a series of webinars for healthcare providers around infant feeding and COVID. So they are available on our website at californiabreastfeeding.org, and under the focus area, if you hover over there, it says COVID-19. There's an area where you can reach all of these webinars. They're free, they're great, complementary to the webinars that have been conducted by CMQCC and CPQCC. And so they can provide further information on how to put the recommendations into practice. Next slide, please. We also developed a shared decision-making guide for parents, and because parents may not know what shared decision-making is. It's in Spanish and English right now, and this can be used in your facilities and downloaded. Next slide, please. And it also includes some of the care options that Susan reviewed, that Dr. Crowe reviewed, and can go through some of those decisions that parents need to make, because as she said, ultimately it is the parent's decision, and this can be a guide to help involve them in those care options. Next slide, please. And I think that's it for me.
So good afternoon. Thank you, Susan and Robbie, and we're so grateful to have Janelle on the line here too. I'm going to ask anybody, great, I see everyone coming on the camera here, so I was going to ask everybody to come on video. I'm Christina Oldini. I'm Associate Director at CMQCC. Courtney and I will be calling on our presenters this afternoon for the remaining minutes to cover some questions that we received during registration for the webinar, and hopefully we can get a few in that have been questioned or submitted today. We'll do our best to cover as many of these as we can. So thank you again. We'll get going. Susan, I'm going to start off with you this afternoon. I have a question that just came in during the webinar. I'm hoping we can start off with that one. Was the infection rate of newborns to positive parents based on moms who were initially separated from their baby, or the total population? Are you aware of this? And then your add-on is, was it over hospitalization or the first month of life?
So the guidance, that the way I have interpreted this data, it suggests that 2 to 5% of infants born to women with COVID-19 near the time of delivery have tested positive in the first 24 to 96 hours. So during that interval immediately after birth, so not during necessarily the first month, but during the either birth hospitalization or shortly thereafter. So does that answer the question?
I believe so, yes. Yeah. Susan, can you talk to us a little bit about or explain the steps to take before, during, and after skin to skin with the newborn?
So some of this is based on just what we have talked about doing at our hospital, and not necessarily based on specific AAP or CDC recommendations. I did mention the CDC specifies that skin to skin, that the prevention of skin to skin there's not data to support preventing skin to skin. But in that context, we also know that respiratory droplets are a concern and a risk for contagion to the infant, and we'd like to avoid that if at all possible. So what we've considered doing is that placing the baby directly on the mom after delivery with either a clean gown or removing the gown that she was wearing at the time of pushing, where there could possibly have been contamination to the chest or the abdomen. We would, at that point at delivery, immediately ensure that she has a mask on, and that she also, so having either a clean gown or having the old gown removed is what we've practiced. And certainly drying the baby off and doing usual routine skin to skin at that point is something that can be implemented. After that, there is this recommendation that the baby be separated 6 feet apart unless necessary. Well, we know that we can't time skin to skin. We can't time the amount of time that it takes a baby to learn to breastfeed. And so it's important to consider that and to not impose unnecessary restrictions on time at the breast and at skin to skin, but certainly maintaining hygiene, hand hygiene, as well as facial mask to prevent any, to minimize the risk of respiratory exposure.
Got it. Just Courtney, before we go to you, I was just to finish up. So I guess we do need to clarify. Melinda was questioning whether that, to your previous answer there, well, would that be vertical transmission then?
It's thought that would be transmission after delivery.
Very good. Go ahead, Courtney. Thanks.
Great. Thanks, Susan. Janelle, I have a question for you that came in ahead of time here. Is there any recommended testing follow-up for a breastfed newborn of a COVID positive mom?
Janelle, can you take your, perfect.
Sorry.
No worries.
That's such a great question. At this point, there has not been any recommendation made for follow-up during the time of breastfeeding generally. There is, of course, the recommendation for babies who are born to moms who are COVID positive to have a test within the first 24 to 48 hours. But there's no recommendation for testing beyond that.
Excellent. Thank you. Christina, I'll toss it back to you.
Great, Robbie. Have you, and this is funny because we saw some earlier input from a team member, at least at UCLA. Have you offered online breastfeeding support, and has there been any evaluation of the effectiveness of these visits or classes that you know of yet?
We haven't personally as a coalition offered the online support, but we advertise online support. Mostly there's been a lot of online support through social media, different groups throughout the state. There is currently an evaluation being conducted at the Arizona State WIC program. Before COVID, they implemented online support through online classes and one-on-one counseling. And they haven't released the evaluation, but it appears to be positive. And so currently the California State WIC program is implementing similar practices throughout the state. So by the beginning of the year, we should see that in the State WIC program, which is serving just about half of our birthing population. So we'll have a huge impact.
Before we go to Courtney, Jeannie, Ms. Reif, and then I believe Ms. Thomas, Genevieve, if either of you want to give us a little bit more information on the Q&A there, if you guys have been able to evaluate any of these new things you've put into place, that would be very interesting for us to be able to see. Go ahead, Courtney.
Great, thank you. Janelle, I have another question for you. Is there any evidence of COVID antibody protection provided by breast milk?
Well, there's not solid evidence of that, but there was one preprint article that was put out in May that looked at 15 lactating mothers who'd been COVID positive. They found COVID in 12 of the 15 of those samples. Now they were testing, actually, I should say secretory IgA to COVID is what they were looking for, not the virus itself. But they found evidence of secretory IgA to COVID in 12 of the 15 samples they looked at. Those were moms who had their milk tested 14 to 30 days after their symptoms had gone away, so that it was sometime later and they were being able to detect this antibody. So there's perhaps some evidence that that occurs, but that was a preprint article from 3 months ago. And as far as I know, the actual peer-reviewed version of that article hasn't been released. So it's still an unanswered question, but there's people thinking that perhaps we will see more of that. I mean, it does kind of make sense that that would be the case, given that, you know, breastfeeding is very protective of many sorts of infections. But to specifically answer the question about evidence, it's not quite there yet.
Thank you, Janelle.
Got it. Thank you. Robbie, this one's for you again. What measures are being taken to get this guidance widely disseminated to the public?
We have a social media campaign occurring right now, targeting parents on our Facebook page. Mainly, that seems to where a lot of the conversation is happening with parents. So that will be ongoing, and as we identify new issues, that's where we will get the information out in that way, and always on our website, but can reach a lot of parents in that way.
Great, thank you, Robbie. I'm gonna address a question that's been submitted live here, and I think it can go to either Susan or Janelle. And it's around the collection, storage, and administration process of expressed breast milk from a COVID positive mom at home to be delivered to the NICU. And I'm gonna just ask a couple questions here, and let's see what you, either of you think. We'd love your guidance around this. Are you transferring all milk to a clean bottle for storage? Are you wiping down the bottle with a wipe? What wipe are you using? Are you accepting frozen milk from a COVID positive mom? And if so, are you wiping down this bottle before storage? So Janelle, Susan, feel free to jump in.
Janelle, I'll comment and then maybe you can elaborate. In the CDC guidance under care for breastfeeding women, they specify a comment about, they know that there is evidence that SARS-CoV-2 remains on surfaces for several hours to days. That being said, there is a lack of evidence to support precautions such as cleansing the breast prior to breastfeeding or milk expression, or disinfecting external surfaces of milk collection devices, bottles, milk bags, as steps to reduce the transmission. That being said, and so mothers may consider additional steps such as these to minimize theoretic potential routes of exposure. But there is not a recommendation, according to the CDC's guidance, to do so. That being said, I believe that we are accepting milk, but that we may have practices, and I'm not actually sure what we're wiping the external surface with. So I'll leave that question to you, Janelle.
Well, I can't answer the one about which kind of wipes either. I don't know, but the last that I knew, we were still advising the outside of the bottle be wiped down. And as you all know, things change fairly quickly, and it's been a couple of months since I was involved in discussions around that. But the last I knew, we were still doing that for mothers who had pumped milk and were bringing it in. I don't think it makes a difference whether she's, COVID positive or not. I mean, we were feeding that milk to her own baby. I doubt that the milk bank would take that at this point, but in terms of the mother bringing it for her own baby, I don't think that was ever an issue. I'm not aware of any babies that we had born to COVID positive mothers who had very severe illness or were extremely premature. So that might change the discussion a little bit for those patients. But as far as I know, the kids that we have had in that situation have been in general healthy and close to term. So yes, we allow it to be provided. Yes, we still have been wiping down bottles as far as I know, and I'm not sure which kind of wipe.
And that we would certainly accept frozen milk from a COVID positive mom. That there would be no reason not
for her
to.
child, yes.
I want to give a little follow-up here. GD answered back, and this was the one that had started and gone ahead as a program to do some online education. They didn't have any formal evaluations, but there were, as she said, some voice positive responses. They did find that the virtual one-on-one consultant appointments were not as successful. The consultants are not able to visualize the latch. And then mothers, birthing persons were reluctant to expose their breasts over the internet, even with the use of an encrypted platform. So that is something to consider. I'm going to go ahead here and throw this one to Janelle. Janelle, do you test partners for COVID?
So in the newborn nursery setting, where I am the regular nursery setting, we have not been testing partners. They're cohorted together with the mother, and we sort of presume they're positive, but we don't actually send the father for testing. The partner of the mother who delivered a baby who's now in the NICU, though, those are routinely tested because it allows the partner to be able to visit the infant since they're going to a different unit. So if they're all cohorting together in the regular couplet care area, we don't test. If the baby's over in the NICU and people are going to want to go visit, then we would.
Got it. We're coming down here on time. Courtney, this is an interesting one here. And it's just kind of someone who's just commenting, and I don't know if Robbie or any of our attendees or panelists want to take this, but there's concern that folks are seeing an increase in moms requesting formula. And here it says right after discharge, but I have a feeling it's upon discharge, soon after discharge. And wondering what this is related to. I don't know if Susan wants to throw in any opinion on this, or Robbie.
I will say that our exclusive breast milk feeding rates for babies born to COVID positive moms has been astonishingly low. And that they are receiving formula in the hospital at higher rates than babies whose moms were not COVID positive. I think it's a disturbing trend that we need to learn from and investigate how we can put measures in place to reverse that trend.
And I heard the opposite in a local hospital in my area in Watsonville, that they were seeing exclusive breastfeeding go up. There was one mom who was COVID positive. They said she was pretty sick, so she chose not to, but the others that did test positive chose to exclusively breastfeed. And, but I would say there's, you know, a lot of fear, and parents just may not have the confidence, so they may feel like they need the formula because you want your baby to, you know, be fed and to thrive. So it could be just a lot of fear-based. We need to make sure the support is there. Even in these times, it's really, really critical.
Courtney and Valerie, let's keep that one on our plate kind of for down the road, because that's an interesting question, and see if we, you know, should we have a webinar down the road, we can come back to these guys and ask them if they've seen any change or what they're hearing on the units. I think that would be interesting. So I think there's one last question here. Courtney, do you want to go ahead and a little bit about support group care? So we've got in a little bit of that. So what about the one
Sure.
now here about discharge instructions?
Yeah, that's what I was going to do. Okay. So we've got great questions. Thanks. We're, you know, unfortunately unable to kind of attack them all and address them all. But Janelle, what discharge instructions should we be providing our COVID positive moms for when they go home?
I think in general, the discharge instructions are around how to safely minimize this respiratory droplet exposure at home, which is really going to be to continue what we have been doing in the hospital. Obviously, we want moms still to be able to breastfeed without very strict limitations around time, but we want them to do hand hygiene first. We want them to wear a mask when they're breastfeeding, and we want them to be somewhat separated, you know, at least 6 feet away from their infant whenever possible. You know, knowing at home you have to do more of the care yourself, and depending on somebody's circumstances, they might be the only care provider, but still we would want them to be hand washing and wearing a mask whenever they need to approach their infant for any reason, diaper changing or whatever. So that would sort of be the main recommendation. I would say the additional thing that we would want to start adding in that we hadn't previously been is, now that we're seeing more recommendations around when somebody can discontinue those extra measures, that would be important to communicate too, because once you're home, there's going to be a lot of open-endedness about how long am I supposed to be doing this for? And after the newborn visit, you may not actually have another regularly scheduled time to have a discussion with somebody about that. So I think especially as those guidelines are coming out and whatever, we should include that also with what we're telling people.
Great, I think that's
Excellent.
thanks for your great job on the questions, everybody. Wow, we really want to thank Susan, Janelle, and Robbie for guiding us really today and taking us through the presentation and the Q&A. We really appreciate it. We want to thank you, all the attendees, for joining the 6th webinar in our series. There will be another webinar in just a few weeks. Please go ahead. If you did not receive the actual invite or announcement from CPQCC or CMQCC, please go in on the websites and go ahead and register, create an account, so you'll automatically get notice of the next webinar. We are so grateful for everyone's time. We know how everyone is so occupied, obviously, in the state with this pandemic, and now with the crisis of the fires throughout the state. We so appreciate everyone attending and supporting this effort. Next slide. So it's our disclosure slide, just to reiterate that every hospital, clinicians, It may not apply to your own hospital, and we always go ahead and propose that you go ahead and check out with the information on your local health department or obviously with the CDC. Next slide. Here is our CME information. So anyone, RNs, physicians, and Ps, please go in and count and, and go ahead and request your CME. All you need to do is go to Continuing Medical Education at Stanford or Stanford Cloud CME, and you will go ahead and see the process there. It's very simple. The code for this presentation today is 38776. Next slide. So a couple people have asked, it is, let me get this down here so I can read it to you correctly. This is our resource site. Very simple. It's California Perinatal programs.org. So ca-perinatalprograms.org. Please check it out. The slide deck and the presentation, the actual recording of it will be up by Monday for sure, and hopefully by Friday. So we thank everybody again, our presenters, attendees, everybody. Thank you for support. And we really are sending strength to everybody around the state and also the nation during this really quite odd time. Thank you everybody for attending. Have a great day.